the view from above. We will look at the nasopharynx. Oops. How can I? Here we go. So, we're talking about the nasopharynx. So, the anatomical subdivision of the pharynx, as you know, has three constituents. On top, we have the nasopharynx, which reaches from the skull base to the soft palate. From the soft palate, we have the oropharynx, reaching to the epiglottis and pharyngoepiglottic fold. Further down, from the pharyngoepiglottic fold, we have the hypopharynx, which ends at the lower end of the cricoid plate at the cricopharyngeus muscle. So on this coronal T2 weighted image, we see the nasopharynx on top, the skull base, the soft palate, this is the tonsil, the oropharynx, and anteriorly we have the vestibulum of the larynx and the larynx itself. So let's move on. So the nasopharynx is an unpaired midline space. As you can see here, it's in contact laterally with the masticator space, the parapharyngeal space, and posteriorly with the retropharyngeal space. Between the parapharyngeal space and the parotid space, we have the carotid space. So on top, the nasopharynx, the masticator space, and further posterior, the retropharyngeal space. We will come to that. So the nasopharynx is bordered by the skull base superiorly. Anteriorly, it is in communication with the nasal cavity. Posteriorly, we have the posterior pharyngeal wall, and laterally we have the superior constrictor pharyngeal muscle. We have the medial pterygoid plate, pterygoid process, and we have the torus tubaris. So the indentation here is the Eustachian tube ostium. So the prominence is the torus tubaris, as you can see here on the coronal image again. The torus tubaris, the indentation is the Eustachian tube ostium. So the middle layer of the deep cervical fascia invests the nasopharynx, oropharynx, and hypopharynx. There is the deep layer of the deep cervical fascia that invests the perivertebral space. And then we have the ala fascia, which is the lateral border of the retropharyngeal space. So the ala fascia, we will see later on that there is a medial continuation of this ala fascia as well. The main constituents of any pharynx is the mucosa. We have minor salivary glands, and we have lymphatic tissue. Lymphatic tissue, as you can see on this sagittal image, is in the roof of the nasopharynx. And as you can see here, anteriorly, the nasal cavity, superiorly, the floor of the sphenoid sinus. So there is a continuation from the nasopharynx into the skull base, into the floor of the sphenoid sinus, and into the basosphenoid and into the baso-occiput. And you see only part of the baso-occiput is actually covered by the prevertebral muscles. My conception always was the prevertebral fascias extend much more anteriorly, but they don't. You see, they attach to the basosphenoid, but baso-occiput, but the basosphenoid and floor of the sphenoid sinus are uncovered. So there is mucosa. On the surface, we have minor salivary glands, lymphatic tissue. We have the pharyngeal tonsil, that's a little bit of repetition. We have seen the torus tubaris, and what you can see here again is the torus tubaris. You see this is cartilage, this is why it's bright on T2. The ostium is this very small narrow gap here. Then we have the levator-veliopalatini muscle, and when you go from the torus tubaris, this bright structure, the levator-veliopalatini muscle is the dark line that you have here on the right and on the left side. We have the supraconstrictor muscle, which is hard to find because it's very thin. And we have a combined structure, which is the supraconstrictor and the tensor veliopalatini muscle in the lateral wall. Keep in mind, the supraconstrictor muscle is attached by an aponeurosis to the skull base. This is the pharyngobasilar fascia. So let's look at the mucosa. So it's the Eustachian tube and its opening that is formed from the first brachial arch and pouch. So anteriorly to the torus tubaris, the Eustachian tube ostium, we have a mucosa that is different from the posterior mucosa. It's thinner. This one resembles the nasal cavity squamous epithelium. The one at the posterior wall and in the lateral pharyngeal recess is derived from entoderm and resembles the oropharynx mucosa and is thicker. And due to the different developmental origin, this one has a propensity for the development of poorly differentiated carcinomas. So that is a difference. Again, on the sagittal image, you see the roof of the nasopharynx, you see the basosphenoid, the basoocciput, and the floor of the sphenoid sinus. Let's look at the lateral wall. So in the nasopharyngeal mucosal space, we talked about the combination of the supraconstrictor muscle and the tensor. This is actually the tensor veli palatini that you better see on the right. Here you see it on the right, and here you can see it on the left. We have seen the torus tubaris. We talked about the mucosa being thicker posteriorly. Here we have the lymphatic tissue, the pharyngeal tonsil. So the lateral wall is perforated by the hiatus Morganii. This is a gap, and the hiatus Morganii is the gap that is perforated by the Eustachian tube and by the levator veli palatini. Eustachian tube anteriorly, levator veli palatini posteriorly. So the posterolateral wall contains the recess of Rosenmüller, and it also contains the continuation of lymphatic tissue. So you see the pharyngeal tonsil, and you see the extension of the tonsil into the lateral pharyngeal recess, or we call it the recess of Rosenmüller. On the coronal plane, again, you see the torus tubaris, the ostium, and here, where you have the four, this is the lateral pharyngeal recess. So we talked about the anterior, the lateral. Now we come to the posterior wall. The posterior wall is in contact with the retropharyngeal space, and now we can see this is the nasopharynx, and here we have the alar fascia, which is the sagittal slip of deep cervical layer. But there is a medial continuation that separates the true retropharyngeal space from the danger space, retropharyngeal danger space. And here we have the prevertebral muscles, more medial. We have the longus colli. More lateral, we have the longus capitis muscle. So medially, longus colli, laterally, longus capitis muscle. And here we have the supraconstrictor muscle. As you can see, here we are at the lower border of the nasopharynx. In the retropharyngeal space, you frequently see lymph nodes on the left, on the right, and this is a sagittal image depicting the lymph nodes. We've talked about the roof already, and the contact of the roof to the floor of the sphenoid sinus. So in the roof, we have the pharyngeal tonsil. Lateral to the roof, we have the Eustachian tube ostium, the torus tubaris. But when we stay, again, torus tubaris, Eustachian tube ostium, lateral pharyngeal recess, we see here the floor of the sphenoid sinus. Further posteriorly, we have the basoocciput and the insertion of the prevertebral muscles. When you look again from the lateral pharyngeal recess, you see the compact bone of the floor of the sphenoid sinus, and here we have the foramen lacerum. As you know, on top of the foramen lacerum, we have the internal carotid artery, and here we have Meckel's cave. So the depth of the infralateral recess of Rosenmüller's fossa is in direct contact with foramen lacerum, and this is very important to remember because it's a pathway of extension. So this may occur in a direct way or in an indirect way via the infralateral recess to the foramen lacerum. What we can see here on this T1 weighted image is not only the difference in caliber of the mucosa, but we see this white mucosal line. And look for this white mucosal line because this should be preserved. If there is an interruption or effacement, if it's gone, this is not normal. The pharyngobasilar fascia, as you can see here, has a zigzag course laterally, posterior on the surface of the prevertebral muscles. Then you have this indentation, and on the right we continue the pharyngobasilar fascia continuing laterally, continuing anteriorly, in combination on the surface of the supraconstrictor muscle and the tensor veli palatini muscle. We've talked about the Eustachian tube. If we want to see the Eustachian tube in a proper plane, we need to angulate either the plane of acquisition or our NPR. So this would be a CT in a normal acquisition plane. Here we have it in a 45-degree inferior angulation. And when you do Valsalva, you know the Eustachian tube opens. Here we have the torus tubari again. This is the Eustachian tube. It continues into the temporal bone. This is the nasopharyngeal ostium. Here we have the tympanic cavity ostium, and then there is this narrow portion which we call the isthmus of the Eustachian tube. So 45-degree angulation. Pathways of tumor extension, important to know because you see what you know and you look at what you know. So direct, we talked about this, there's direct extension into the floor of the sphenoid sinus because this is in the roof of the nasopharynx. We have a gap in the lateral wall, which we call the hiatus Morgandi, perforation by the Eustachian tube and the Levator palatini. There is an extension towards the foramen latium via lateral recess, via the osmellus fossa. There may also be an extension, not only via foramen or latium, but also ovale. This requires that the tensor veli palatini muscle will be violated or will be breached. And then there may be an anterior extension. We are a little bit low for the pterygopalatine fossa, but always look at the pterygopalatine fossa and look at the clivus. How can the nasopharynx be reached? And our endoscopic surgeons, the rhinologists and skull-base surgeon, they have defined 3 areas that can be reached by an nasal endoscopic access: retromaxillary, inferior pterygoid, this is the number 3, and they have defined tubopharyngeal space, which in effect is the Eustachian tube, is the torus tubarius, and is a space that is defined by the levator veli palatini, the levator veli palatini medially, the tensor veli palatini laterally, and is the space to reach the internal carotid artery. So once you do surgery in this place, the most important structure not to violate is the internal carotid artery. So you have to know where it is. So the levator veli palatini, this one, is consistently anteriorly to the internal carotid artery. Levator veli palatini, internal carotid artery. The longus capitis, this one, is a good medial landmark to the internal carotid artery, and the tensor veli palatini muscle is about 2 centimeters anterior to the internal carotid artery. So our endoscopic surgeons want to know these structures, and if surgery is a topic, you can relate to these structures: tensor veli palatini, levator veli palatini, longus capitis muscle. As you can see, the internal carotid artery can have quite a variable position, so you may provide a navigation set with thin section or 3D T1 in order to have a navigation. Let's move on to nasopharyngeal cysts. We have 2 types. The first one is the Tornwald cyst. It's a midline cyst. It's in the position of the bursa pharyngia. The bursa pharyngia is the rostral end of the chorda dorsalis. So it's a retraction of the notochord in an embryonic stage. And in this position, we have a formation of the Tornwald cyst, which is in direct attachment to the posterior wall without intervening lymphatic tissue. If you have an off-midline location, and if there is, you see here, there is the mucosa and there's lymphatic tissue in between, it cannot be a Tornwald cyst. They may off-midline, intervening soft tissue, so this is a mucus retention cyst, so think of this different. There is another cyst which has a pedunculated connection to the skull base, but it is very rare. We call this the craniopharyngeal cyst. If you may remember that we have the formation of the antipituitary lobe derived from the nasopharynx, so we call this the stomateum. At 3 to 4 weeks, it starts indenting into the sphenoid mesenchyme. It connects to the diencephalic prominence, the encephalic prominence is the posterior lobe. You see there's formation of a duct, so this is the stomadeum, and this is the later Rutgers cleft pouch. So this usually obliterates, but when it stays open, this is the craniopharyngeal canal. So there's a perforation from the anterior lobe through the floor of the sphenoid sinus into the nasopharynx. And here I show you one example from the literature. You see a continuation from the anterior pituitary fossa along the sphenoid sinus into the roof of the nasopharynx with a CSF-filled cyst formation. So this is a patent craniopharyngeal canal, and so we call this a craniopharyngeal cyst. And there may be CSF rhinorrhea if this cyst is leaking or ruptures. Along this craniopharyngeal canal, we may have an ectopic adenohypophysis, so the anterior lobe may be in the wrong position, may be lower. So you may find it on the floor of the sphenoid sinus, the anterior pituitary lobe. And the third entity that may look similar, but is something completely different, is the notochord, is the chordoma. You see this ends also in this position of the bursa pharynga, and here you have another pseudocyst. This is solid tissue, cartilaginous. So we're talking here about a chordoma in the roof of the nasopharynx. Coming back to the craniopharyngeal canals, I think this is not too important to know, but just to give you an overview, these canals are incidental in about 0.4%, so quite rare. They may contain an ectopic adenohypophysis, as I mentioned. When the canal is usually larger, they may contain cephalocele or meningocele. They may contain tumors like a craniopharyngioma, a dermoid or teratoma, or a combination of a meningocele, cephalocele, and a tumor. So we call this type 3. Just to have mentioned this, don't keep this in mind. We will not ask this in the test. Now we move from the nasopharynx to the deeper spaces. An overview again. We've talked about the nasopharynx. Laterally we have the masticator space, we have the parapharyngeal space. Further lateral, the carotid space and the retropharyngeal space. The deep space, again, remember, middle layer of the deep cervical fascia. The superficial layers invest the paired lateral spaces. So, midline space, the retropharyngeal space. Now again, we see the ala fascia, the medial continuation, separating the true retropharyngeal space from the danger space. The middle layer of the deep cervical fascia is the anterior border of the retropharyngeal space. The ala fascia is the lateral border, and the deep cervical layer is the posterior border. Imaging does not distinguish the true retropharyngeal from the danger space. No way. You have to, just to keep this as a concept in mind, that the true retropharyngeal space closes at about T3, while the posterior compartment, the danger space, continues into the upper mediastinum. So any lesion within the retropharyngeal or the danger space, we will keep this as one space and as one lesion. So we'll talk about the retropharyngeal space, and any lesion there may have the propensity to extend into the upper mediastinum. So the contents: fat, lymph nodes, and further posterior. This is the virtual space. Can we see the retropharyngeal space? Yes, we can. You see here, this is the supraconstrictor muscle. There's a tiny amount of fat. You have these tiny nodes in the lateral retropharyngeal space. Occasionally you may have fluid. We will talk about this when we talk about the pathologies. This is the XOT2. This is a sagittal image where you can see that there may be fluid contained. I think fluid is not always an abscess. It is very rarely an abscess. Usually it's something else. It's fluid. Let's talk about the masticator space. So the masticator space is bordered anteriorly by the buccal space. It's lateral to the pharyngeal mucosa space, lateral to the parapharyngeal space, and anterior to the parotid space. We can divide the masticator space into an upper compartment, which is suprazygomatic. You have this zygomatic arch, so it's suprazygomatic, and the major component is infrazygomatic. We can further subdivide the infrazygomatic component into the medial one and the lateral one. lateral pterygoid, medial pterygoid being the medial components, and the masseter being the lateral components. On this image you see suprazygomatic, infrazygomatic, lateral pterygoid, superior belly, inferior belly, medial pterygoid muscle, masseter muscle. I think that was too much, no? We continue, and there will always be some repetition, don't worry. So the mandible is the main osseous component of the masticator space, and of course we have the TMG contained within the masticator space. We talked about the masseter muscle laterally. We've seen the lateral pterygoid superiorly and the medial pterygoid muscle inferiorly. And you see there is a fat line space between the two pterygoid muscles, and you see there is a close attachment of the masseter muscle to the ascending ramus of the mandible. There is also the mandibular division of the trigeminal nerve. So here we have the mandibular nerve. So let's move on to the parapharyngeal space. It's adjacent to the masticator space, between masticator and nasopharynx. It is mostly anterior to the carotid space, has a component that extends laterally to the parotid space, and is lateral to the retropharyngeal space. So the parapharyngeal space actually is in contact with all the three layers of the deep cervical fascia. The yellow one is the superficial one, the middle layer, and the deep layer of the deep cervical fascia. So the parapharyngeal space contains fat, so potentially there may be a lipoma, lymphatic vessels and nodes, so there may be a lymphangioma. There is extensions of the pterygoid venous plexus, and we may have ectopic minor salivary glands, but all these are exceedingly rare, so fat is the main component of the parapharyngeal space. And keep in mind, any disease within the parapharyngeal space properly usually arises from the adjacent space. There's an important communication of the parapharyngeal space, which is inferior into the retromandibular space. So when you look at this drawing, you see that yellow line being continuous above the submandibular space. This is not true. Just look at this image. Here you can see there is fluid in the parapharyngeal space extending further posteriorly and around the submandibular space. Again, look on the normal T2 weighted image. The fat in the parapharyngeal space extends around the submandibular gland into the submandibular space. So continuation of the parapharyngeal space with the submandibular space. And there's also continuation along the stylohyoid muscle to the floor of the mouth. So this is the sublingual space. The sublingual space is not fascia lined and crosses the midline. So fluid in the parapharyngeal space, in the sublingual space, crosses the midline, and you also have fluid on the left side. You see this patient is really sick, is intubated, so this is a parapharyngeal space abscess. So I come to the end. I think I saved a few minutes. So let's summarize. The nasopharynx is in contact with the masticator space, the parapharyngeal space, the retropharyngeal space, in contact with the oropharynx inferiorly, and the skull base superiorly. It contains mucosa, and we heard that it's thinner anteriorly because it resembles the nasal cavity squamous epithelium. It's more thick posteriorly because it's derived from the entoderm and thus resembles the oropharynx mucosa. This kind of mucosa will give rise to very undifferentiated tumors, contrary to the mucosa that is more anteriorly to the Eustachian tube muscle. We also have minor salivary glands. So an entity that we will encounter in my next lecture will be adenoid cystic carcinoma. Very rare, but minor salivary glands, you could keep it in mind. Keep in mind the lateral wall is perforated by the Eustachian tube here. The levator palatini muscle, this is the muscle. And what we see on the surface in the lateral wall is not the tube, but is the torus tubarium, is the cartilaginous nasopharyngeal ostium of the Eustachian tube. The roof is in contact with the sphenoid sinus floor, in direct contact. It's separated from the floor by the pharyngobasilar fascia, but this is, not a, it's a thick fascia, but it's on the surface of the prevertebral fascias, so it's not a good protection of the floor of the sphenoid sinus. We have continuation of the lateral recess, Rosemueller's fossa, to foramen lacerum. Remember, we have the border laterally, that is the tensor palatini muscle. We have this definition of the tubopharyngeal space. It's not a true space, it's a corridor for endoscopic therapy, which contains the levator palatini muscle being exactly anterior to the internal carotid artery. It has the tensor palatini muscle being 2 centimeters anterior to the internal carotid artery. I did not put here the longus capitis muscle because it's more medial and more posterior, but this provides guidance to the internal carotid artery for the endoscopic surgeons. Think of retropharyngeal lymph nodes, and there's a difference between nasopharyngeal cysts, keep in mind the Dornwall cyst and the mucous retention cyst, and the craniopharyngeal cysts. In the craniopharyngeal cyst, and I would say in any midline cyst and in any cyst in the nasopharynx, have a brief look at the skull base that you don't miss craniopharyngeal canal. And with this, I'd like to thank you for your attention. Thank you very much.